Boa noite a todos, sejam
Good
bem-vindos.
evening, everyone. Welcome to one more BJAN webinar. It's our last webinar of 2024. Now, of course, we'll have a webinar that's very special with an international guest broaching a theme which is relatively controversial. There are some controversies involved that deal with the use of antifibrinolytics and the concept of hepatic transplant. To approach this subject, we'll have Dr. Eduarda Schütz Martinelli. Dr. Eduarda, she's an anesthesiologist from Santa Casa, Porto Alegre, but right now she's a clinical fellow in Toronto General Hospital, working on several areas of anesthesia, especially the context of liver transplant. The main focus point right now is organ transplant, of course. He shares a large experience in this area at the same time in the use of these medicines and in indication and controversies that are involved with the use of antifibrinolytics in this population. So within this context, she recently published a paper in the Brazilian journal that deals with this, an editorial that is broaching and discussing the controversy that involved this. It's being shared between you. Download and sharing the link to download of this paper. And there are not PhD thesis he approaches the clinical trial, the use of this medicine, its efficiency and safety, and the context of liver transplant. So at the end of the presentation, we'll have a space for discussion. So I request our colleagues that are watching us to share your opinions and your questions in the Q&A, whatever item you may share your questions, and at the end of the presentation of Eduarda, I will read your questions and we'll start the discussion about the subject. Okay, before I pass the floor to Eduarda, I'd like to remind you so that in the next month we will have no webinar because it is the Brazilian Journal of Anesthesiology Congress. We will have our stand. We will have our stand together with the Brazilian Society of Anesthesiology stand. I ask our colleagues to visit us, our space. So please, Eduardo, you have the floor. Good evening, everyone. So thank you, André, for the introduction. Thank you for being here, all of you, today in the webinar this evening. As André already said, the webinar will be based on our editorial about antifibrinolytics and liver transplant. So I'll share the screen. I'll share the screen here. You see my screen? Yes, antifibrinolytics. So the learning points at the end of this webinar are, I'd like to speak a bit about the concept of hyperfibrinolysis, the indication of erratum, indication of transplant and surgery, most diverse types of surgeries, prophylactic use of transplant as well, several scenarios in liver transplant as well, and the therapeutic use and liver transplant. So also speaking about risk, benefit, and any doubts that may eventually come up. So as we already know, liver transplant will be involving large amount of blood loss and the need for transfusions. We've had a lot of surgical advancements and diagnosis advancements that improved during the years, but the role of antifibrinolytics still continues to be controversial in this scenario. And bleeding within the transplant context, it is multifaceted. It can be surgical. The profile, if they have a different type of coagulation, the ischemia of the organ, hyperfibrinolysis as well as a large contributor towards bleeding in this context.
Então, falando pouco de hiperfibrinólise, que é importante.
About hyperfibrinolysis, it's important in this context, differentiating a bit of hyperfibrinolysis, you must already know so, but it's worth repeating. Hyperfibrinolysis is different from fibrinolysis because hyperfibrinolysis is a natural process of our bodies. It will dissolve blood clots. That's the end stage of the coagulation cascade. When we're talking about hyperfibrinolysis, we're going to be referring to exaggerated fibrinolysis. It's going to be out of control, that the body will dissolve blood clots in a very quick, excessive manner. This can lead to serious bleeding and potentially fatal bleeding, increasing the risk of mortality. during a transplant, it will occur more often during anhepatic and post-repercussion as an incosacosmin, which will degrade in an exaggerated manner the fibrin, which functions as a glue for blood clots. So just to illustrate on a chart so you understand why is it so important to understand hyperfibrinolysis in the transplant context. Remember that fibrinogen is a main coagulation factor that we have. It corresponds to 80% of the coagulation factor. So when we have hyperfibrinolysis, and this factor is going to be a large contributor within the bleeding context. So since it is so noticeable, so impactful in liver transplant, how will I identify the clinical diagnosis of hyperfibrinolysis? A lot of the times it's very challenging because it cannot be detected with standard blood clot tests like the TTPA. These tests, they will assess the efficiency of the orthogonal coagulation and the capacity of formation for forming blood clots, but it will not assess the degradation quality. There are indirect signs of hyperfibrinolysis within these standard tests, but they are not specific, like the enrichment and fibrinogen. We could suppose that there is an increase in fibrinolysis. That's why fibrinogen is going down. But for instance, an increase in the degradation of fibrin products, such as the Drimex, those could suggest this. But these days, there's no sense in using these standard blood clot tests with this intention of detecting hyperfibrinolysis, because the gold standard we have now are the elastic tests. As the elastic disc test, elastography, the TEG, and Crumble Rodham, they can detect accurately hyperfibrinolysis. They will analyze the formation, stability of the blood clot, and the degradation in real time. So these will be the only ones that are able to assess the blood clot as a whole. Of course, they're also not perfect, but they're the best thing we have right now. So you need at least 20-30 minutes for hyperfibrinolysis to come up. They may be false negative results. Well, we have the blind spot for the ROTM that we talked about. For instance, if in the ROTM test or TEG test, hyperfibrinolysis does not come up, we cannot be 100% sure that this patient really does not have hyperfibrinolysis. It may be within the blind spot. Just to put a bit more context on this, the awareness of ROTM, the TAG is lower. It's something that we must always do, especially within the liver transplant context. Just for a small intro to ROTM, a real example of the transplant that we have in the Santa Casa hospital. The XSTEM channel, they will assess the blood clot started for the intrinsic pathway. It's the most common channel that we detect hyperfibrinolysis. The main parameter to identify hyperfibrinolysis ML, maximum lysis. If ML is above 15, it will suggest hyperfibrinolysis. Now, the FibChem will assess intrinsic blood clots. It's a channel that is more useful for patients that are being treated with heparin or patients with some disturbia, specific blood clot, like hemophilia. Or in the liver transplant context, we don't have a lot of these patients like we have in a heart disease. This channel is not so important for us in ROTM, so we can assess the maximum lysis parameter as well as the intent. FibChem will assess fibrin. So it's useful to assess this contribution of fibrin in the shaping of the blood clot. It will assess the plaque, the platelet. And in hyperfibrinolysis, the FibChem can assess the blood clot because the blood clot fibrin will be quickly degraded. FibChem, for instance, it will not be as sensitive as XSTEM to detect hyperfibrinolysis, but it will make us understand if the problem is also the deficiency of fibrinogen, which can be relevant in the context of liver transplant. So I'm just showing you the APTEN channel. The APTEN channel is very specific for hyperfibrinolysis, and it's used if the problem of the patient is hyperfibrinolysis. This test is done with an inhibitor of fibrinolysis, tranexamic acid, do the XSTEM test. If in the abdomen the blood clot is stabilized, because the excessive lysis disappears, so the blood clot becomes normal, air quotes, normal, means that the patient does have hyperfibrinolysis because the blood clot became stable at the presence of the fibrinolysis inhibitor. So why don't we use it as frequently? Why in the prior photographs that I showed you of a real transplant, we did not use the aptan? Well, because actually the only reason why hyperfibrinolysis appears in the intestine is the patient has hyperfibrinolysis or is an artifact. So in the liver transplant context, we don't even think that this could be pathogens. We really do consider the patient to have hyperfibrinolysis. Sure, so I'm talking about this within a context that is a economy, that eventually we need to have this in the public health system. Because we need spare materials, spare people, because in the real world, we'll use the 4 channels, even ROTM itself. But if I'm not wrong, a blood sample shows 4 channels. So just to reinforce to you the identification of hyperfibrinolysis that feature men are rodent, if you're observed as extant, to focus on the value of the ml. If so, then it suggests hyperfibrinolysis. So if hyperfibrinolysis does not appear in rodent, we cannot exclude the diagnosis. And if we must choose only one channel of rodent, if the other channels are not working, there's no money to be able to do all the channel tests, we would choose extant. Remember that rotin will not assess the platelet situation, but that's out of the scope. So we have hyperfibrinolysis, diagnosed hyperfibrinolysis. So how do we treat it? The antifibrinolytic medication that is available for many years now, since the 60s, and they will divide into 2 main groups, which is the protonine group and the tranexamic acid and methoxylic. The protonine is highly efficient. It has a profile that is less favorable risk-benefit due to the cessation has had several studies with the increase of kidney failure and thromboembolic events. So, and these days, it's not back for usage, not just in liver transplant, several types of surgeries. Now, the aminocaproic acid has a significant relevance in studies that show similar efficiency, but due to the kidney situation, the higher cost for aminocaproic acid, its interest went down, and it was replaced highly in the daily use and work as well for transamine. So transamine is recommended by several studies for the prevention and treatment of hemorrhage, hyperfibrinolysis, and large-scale surgeries in 2011. The WHO, they asked tranexamic acids to the list of essential medication. Strong recommendation of the guidelines for the treatment of periparatory serious periparatory bleeding has been consistent over the years. The use of transamine in several surgical contexts, for instance, liver transplant, myocardial surgery, obstetrics, trauma, orthopedic procedures. It's important that transamine can be beneficial, and it's used therapeutically and sometimes prophylactically. So, speaking about prophylactic transamine, it has proven efficiency in several types of surgery. This trauma, postpartum hemorrhage, cardiac procedures, but it was still not backed, and liver transplant surgeries in a few scenarios. For instance, trauma, postpartum therapy, the early usage will actually show the reduction in mortality for these patients. And we have extremely relevant studies dedicated to transamine in a prophylactic manner. In a few contexts, for instance, this is what I showed here. The titles of the papers: the optimal study, the crash, that's a trauma study, which is postpartum hemorrhage. So, several studies, and spinal trial as well. So, the complication that most concerns us with the use of tranexamic acid is the increase in thromboembolic risk. When it comes to the increase in risk of thromboembolism, there's a lot of controversies in literature. For instance, health study for post-effective study here, it vaccinated at random surgical patients on cardiac surgery receiving a gram of transamine at the start of the procedure. So the studies indicated that even though tranexamic acid is beneficial to control bleeding associated to a slight increase in thrombotic complications, so they could not prove the non-inferiority of tranexamic acid. So the Helix study also showed that patients that were, there's a study that patients that went through resections, liver resections, showed that these patients could have higher complications. They presented higher complications, for instance, re-intervention. In the study of HALT, which is also a recent study, it's a recent trial, for prophylactic transamine and acute gastric virus, it showed that there is a large increase in thromboembolic events for these patients or tranexamic acid events. So just a bit about coagulation for cirrhotic patients. Why could this concern you? These patients, why this concern for thromboembolic events? Why did they take you to concerns with prophylactic administration of tranexamic acid? Our cirrhotic patients with cirrhosis, they have alteration of the procoagulant factors as well as anticoagulant factors. So due to this delicate balance, there's a larger concern in the use of tranexamic prophylactic. So these patients, they'll have an increase in endothelial function with the increase of nitric oxide, leading us to a higher proportion of bleeding and anticoagulation as well. At the same time, there will be an increase of two coagulation factors, not just two factors, integrate and lontinibranch. The disease, the end-stage liver disease, will interrupt the homeostasis of coagulation, lead us to a diminishment of levels of almost all procoagulant factors, as we know, but also some anticoagulant that are produced by the liver. Hyperprotein C as antithrombin 3 can be reduced as well. So even though there is no clear evidence showing the increased risk of hypercoagulation through prophylactics and liver transplant, more robust studies, more robust trials, they are highly desirable to assess the viability of this use in the context of liver transplant. So what do we have regarding risks and doubts? It's crucial to be a study to determine that there is a specific population of patients or liver patients that will benefit from the use of transamine without exceeding the potential prophylactic transamine. So patients with total thrombotic states, liver, kidney insufficiency, these can have an increased risk of thromboembolic events. These individuals can have a higher risk and a benefit. Of course, there is no confirmation to say something concrete about this. But we will follow the recommendation in liver transplant called the ROTM tank for the use of transamine. On top of that, we also know that after there is the revolution of the organ, there is a quick recovery of hyperfibrinolysis in most patients. Sure. That brings up matters about the need and the impact of prophylactic transamine within the transplant context. Specifically, it's uncertain if transamine would significantly alter the hemoderivates that is necessary before stabilization. Before the stabilization of the coagulation of the patient, if in this case, if there actually is a reduction in transfusions, this will translate to a reduction of mortality for all the patients. So, speaking now about transamine using that therapeutic matter in transplant, supported by several medical groups. Over the years, the European Society, they focus on their guidelines consistently that the benefits of the treatment of hyperfibrinolysis that is documented in liver transplant surgery. So we have a meta-analysis, 69 trials that indicated that transplant reduced the requirements in terms of hemocytes in comparison to the placebo without increasing the risk of several thrombosis. The other study, a retrospective cohort of almost 3,800 patients that it reduced the reduction of the need for transfusional hemocytes and reduced the risk of thromboembolic events and several receptors for liver transplant. So, including those patients also that had a low risk of bleeding, and they could also have a higher risk of thromboembolic. They Cochrane with 33 trials, involving almost 2,000 patients going transplant, did not find a significant difference in mortality at 60 days. With these patient groups, the retransplant rate and increase in incidence of thromboembolic events within the transplant groups and control groups. So the conclusion about the results are based on small trials, small samples of patients. So risk, of course, risk of randomness. Another doubt within the application of transplant and liver matter is the dosage, the ideal dosage for patients with liver disease to treat hyperfibrinolysis is still unknown. Currently, we use this at most 1 to 2 grams or at most concentration of 30 milligrams kilo at a total of the application for the patient. Now, when it comes to the aminocaproic acids, if anybody uses this, administering doses that will vary from 0.25 to 2 grams, maximum 5 to 10 grams. So, to close our webinar, currently the MS prophylactic application of antibiotics and transplants, liver transplant, it is not well found that it is prudent to base our decisions and the results of the plastic test and avoid routine use of antifibrinolytics. Other studies are concluded. And for the antifibrinolytic therapy, it must be considered for patients of transplant with significant bleeding that have a hyperfibrinolysis suspected that is confirmed by the elastic disc test. So, summarizing the main aspect of periperitoneal coagulation and the liver transplant context, it is also essential to guide the usage of these antibiotic mitigating added risk and this population which is vulnerable and needed, of course, randomized clinical trials controlled with power to determine the efficiency and safety of prophylactic transplant and the liver transplant population before it can be recommended in a routine manner. I know that André already commented on this before, but it's worth saying again. My PhD thesis is about the administration trial, about prophylactic administration and transplant in the context of liver transplant. We hope to have more results. We'll hope to have more results to show you, to share with you. Thank you very much. Okay, great. Eduardo, can you hear me? Eduardo, can you hear me? Great. Thank you very much. Great presentation. I think it was a very focused presentation. Really gave us a message. At this point, even if
na droga em diversos cenários, no contexto do transplante
hepático, the context of the liver transplant, the recommendation of the literature for prophylactic administration, getting into the administration or therapy, you cited regarding the ROTM, a cohort of 15% fibrinolysis while we wait for other colleagues to ask their questions. In our Q&A window, our question, so in our experience, as have you seen in Canada, this cohort line is followed in a rigorous manner. There's only about 15% or more discrete fibrinolysis, so an increase of the attaining below 15%. Is it treated there, or are they more conservative or only above 15%? Good question, because as tranexamic acid is still very controversial, especially at liver transplant. I think it really depends on the experience of the service. So it really depends on the service. It depends, of course, on the anesthesiologist, surgeon, will a lot of time we share the decision with the surgeon. But There's a lot of the time it is quite slightly below 15%. And will be in literature, but you see that there's a lot of bleeding. The corrected other factors. The patient is a patient that is a serious patient, or it has it's coagulating. Hyperfibrinolysis is not coming up as much, so maybe it is good sense to treat with tranexamic acid as a patient, but it is not a behavior that, for purposes, it could be done, for instance, or a few anesthesiologists would agree upon. So I think it depends on the good sense. The assessment of the context is perfect. In terms of dosage, we decided 1 to 2 grams, the max dosage of 32 milligrams per kilo. In a scenario that, for instance, liver transplant, 20% lysis bleeding, you have those initial dosage, for instance, around a gram, right? You repeat this, Rodham. How long after do you repeat this? How much time afterwards? And if you document that, or there's a certain degree of fibrosis, if the following Rodham, is there a limit for this? Recommended dosage of a gram, what more or less is the strategy that you seek to use and that you've seen in your service. Right, so it also depends on common sense, but I would administer first a gram. This patient will 10 milligrams kilo first dosage. And after a certain point, a certain period, it says 15 minutes, you reassess the Rodham, and you see if there's still hyperfibrinolysis, follow through with the surgeon, the bleeding, and I wouldn't administer another gram, but I would be 10 milligrams kilo. But remember, don't go over 30 milligrams per kilo. We have a pretty old study that, if I'm not mistaken, was 60 milligrams per kilo. That patient had an increase in convulsions. So it's not a dosage we use more these days. So about 30 milligrams kilo per patient. It's very well backed in its usage, but could. Answering your question, it could. Right. In terms of routine, rest of the tank or the Rodham and liver transplant, you generally based off of Rodham post perfusion, post arterial. Is it a post-op? What is the routine for investigation? The standard of coagulation standards and, of course, hyperfibrinolysis. Okay, well, not thinking about financial biases. We don't have a financial bias. Ideally, the best scenario would be 3 Rodhams, 3 Rodham samples. The first one is the base Rodham for the patient. Second is the after arterial reperfusion, 15-20 minutes after arterial reperfusion. At most half an hour, you collect Rodham. And at the end, when it's over, the surgery is over, and in the ICU context, only the patient is presenting some bleeding. The patient is bleeding a lot for drainage. You're thinking about re-intervening and there's some sort of bruise during the exam. Repeat the Rodham, but there is no context of bleeding. It's not common to redo the Rodham. Right, perfect. Okay, there's a question. Interesting question. So, Dr. Emanuel Velasco, yes, and your experience, would you use the tranexamic acid on the patients that are already bleeding, but there is no evidence of hyperfibrinolysis? It's a very interesting question. You see scenarios, even with the Rodham, with a lot of alterations. So a lot of the time, the surgeon would request that we have some measurement done from intervention, including transamine. This has happened with me as well before. So what is your outlook regarding this? Do you use transamine in an empiric manner or not? A good question, because as I had cited during the presentation, we have the blind spot for Rodham. The sensitivity, it's good. Tag is slightly lower, but still we have, in the cases of light to moderate hyperfibrinolysis, we have a blind spot that may not show up in Rodham. So speaking to the surgeon, assessing things, same deal. Speaking to the surgeon, okay, they're still bleeding. At the start, it doesn't seem to be hyperfibrinolysis. For us, it's a suspicion of hyperfibrinolysis within the context of a liver transplant. For me, I would do so. I would like to use transamin with this patient. I would. But since there are surgeons that request it, there are some that reject it or refute it completely if you don't have a backing, something to show them. Okay, look, this is my ROTM. There's hyperfibrinolysis. I have to use antifibrinolytics. So it's gonna depend on the context, where you are, what team you're with. But yes, I would still do so. I would use TXA. And another thing, Rodden, the elastic disc test, they're still the best test that we have these days. The best efficiency, the most effective to assess hyperfibrinolysis is a bedside test that we have when it comes to blood clotting these days. But they are limited; they have limitations. So that's why I think it's worth it to do this work within the assessment of prophylactic transamin, because a lot of the time it's not going to show. So it brings us back to this question: okay, do we use transamin or do we not use it? And on top of that, we have services that have ROTM, but there are medical services that don't have it. So they have liver transplant, they don't have ROTM. We know that this exists in Brazil. We know this is happening in Brazil. So yeah. I think that within this controversial matters, lack of evidence, that's what we need, these new studies, new trials to guide us a little bit better in these situations. But still, we have the possibility. A lot of colleagues still do things empirically, and it's going to depend what your negotiation with the team itself. That what Eduardo said, it's right. I mean, there's surgeons that will be more regular in the use of therapy like TXA, and there's others that will be a bit slightly more not as receptive because of thromboembolic events, and there's a lot of scenarios. So it gives us a wider base to be able to use TXA in an empirical manner. So the other question we have here, it's from Dr. Angela. A maximum dose of 30 milligrams per kilo could be repeated safely after how much time if they still present hyperfibrinolysis? All right, so we're not gonna start with that dose for the patient. We're thinking about that 30 milligrams per kilo. It would be as a fraction. So we would start with 10 milligrams per kilo with a patient. Say it's a 100-kilo patient, we give them 1 gram. So think about it as a fraction. The total for the patient that is still back in literature, it is controversial. There isn't a dose where you can say, okay, I can 100% repeat this, or I can't repeat it. What you would have as a backing in literature is using up to 30 milligrams in total for the patient. So it's a question that it's still controversial, still a bit of an open question, and we hope that eventually we'll have an ideal dose, ideal total dose for the patient where we can safely apply it, we can turn back this bleeding, helping us in the context of transplant bleeding. So it's great. For people that already use TXA and liver transplant, I don't know if in your experience, Eduardo, more or less that's how it is. But normally, when there is significant hyperfibrinolysis documented by Rotten with a dosage that is relatively reduced to a gram or below 1 gram, normally you rarely correct what's showing up on Rotten. Or you test in the past with lower doses. Really was very effective medication, reduced dosage for correction of what the message shows us. So as Eduardo said, there's a blind spot. There's no 100% sensitivity on the method to detect fibrinolysis, but it's reasonable, it's quite elevated, and the medication is quite effective when it comes to correcting hyperfibrinolysis with really lower doses than 30 milligrams per kilo. And since it's the medication that doesn't have such a short shelf life, within the transplant period, 6 hours effective use, effectiveness time, it's difficult. I haven't had any cases where we needed a higher dose than 30 milligrams per kilo. I don't know if Eduardo has gone through any case like that. Have you ever seen something like that? But so it's something that normally don't even reach that dose. It's going to be a gram tops. Maybe you would add another gram at the end of the procedure. It's tough for us to see a need for really high dose. There's another comment here of Rafael Machado, and the professional, as I said, up to 40 milligrams per kilo per hour. What do you have? Do you have any comments about it? 40 milligrams per kilo per hour? I've never used a dose like that. I haven't either. I think that I did. I'm not sure. But yeah, so 40 milligrams kilo hour. That's a lot. It's a lot. It's a ton. For transplant. They're talking about maybe other surgeries. We're talking to adapt it for the context of liver transplant. So, as we already said, clotting of these patients is pretty different. Think about it. It would put down 40 milligrams kilo hour. Surgeon would go nuts. Even during protein times, I was doing a liver transplant with Dr. Joel back in São Paulo. And at those days, we used protein very much lower doses than what was used in heart surgery in terms of protein during that time. So even if we were using prophylactics at that time, the liver transplant.
Final dos anos 90, início dos anos 2000.
And I started 2000s.
Serviços que utilizavam proteinina de forma profilática eram doses bem mais baixas. Então, no contexto de transplante hepático,
so the liver transplant context with these matters involving the risk of thromboembolic events in a very significant amount, still controversial, as said by Eduardo, very low doses. When we talk about talk about several scenarios and very elevated doses. So we need to check this 40 milligrams per hour because in the Bart's trial, we're talking about high risk bleeding surgeries and heart surgeries. So the aortic artery reoperation will be 30 milligrams per kilo attack, 30 per second, 16 milligrams per kilo R.
Não tenho coragem.
Doses that I am not brave enough to use. I know Eduardo. But no scenario in heart surgery I would use this dose, which has been described in a few trials, but it was the highest dose I found went down. Normally, I think Professor Galliard says 15 milligrams per kilo hour, very reasonable dosage. Attack doses, 30 milligrams per kilo. It's a scenario without a doubt. I don't know, maybe Eduardo could comment on the dosage she's using in her study, but certainly in the context of the liver transplant, work with attack dosage, with the maintenance dosage, that is more reduced than the study for the prophylactic administration, which dose to use. So, I'm back a bit. These are actually very different patients. Heart surgery patients, that the transplant patients, they're pretty different patients. And these questions that folks are asking about the dosage are always worth remembering in liver transplant. It's a patient with a diffuse coagulation. So it's a surgical context that has surgical bleeding. So coagulated patients, they have organ ischemia. So there are several other things involved. So it's not just hyperfibrinolysis. It's gonna deal with other things as well. But talking about the study, our study is about 10 milligrams per kilo. And afterwards, 1 milligram per kilo per hour until the end of the transplant. That's the dosage. That's a reasonably low dosage when we talk about these other heart studies. So that's why we use the dosage that it's actually lower to not run bigger risks. So great. So you can see the Q&A, no further questions. Once again, thank you for giving us your time in this special webinar, our last webinar in 2024. And thank you for all of our audience and really contributed strongly with comments and questions. Thank you for your attention. I wish you all a good evening, and we'll see you in the Brazilian Congress next month. So thank you, folks. Thank you. Good evening. Thank you.